I will really focus on something very important, is the simplified computer-guided implantology way to do computer-guided implantology. So, first of all, computer-guided implantology is very complicated, is very expensive in most of the what you can find in the market. And we've been struggling to try to make the things more simple and accessible to everybody. And this is what I'm going to try to explain to you based on my effort to constantly make things accessible to everyone. So the question here is, to start working in this way. So I have 4 steps. The first one is scanning appliance. So the scanning appliance are things that we put in the patient's mouth during the CT scan take. So do we need scanning appliance? What kind of scanning appliance can we do? And how many kinds of scanning appliance we need in the everyday practice. So I will explain that in a very simple way, and I will really simplify the scanning appliance approach. The second point will be about the CT scan native data. So some cases, most cases, we are dealing with computer-guided implantology using CBCT. But there is a limitation for that, and I will explain to you what's the difference in between a spiral CT result and a CBCT result. I will show you what is a conversion, what is cleaning, and what is segmentation, because I know that most of the dentists have confusion again, talking about what's a conversion. What do we convert? We convert what into what? What is that? Why do we need segmentation? Why I cannot just use my CBCT image and plan implants on that image? And what is the difference in between this and that? So I will go through these questions, which are fundamental, basic questions. You need to have the answer about that before starting anything. Then, of course, implant planning. I will show how I have been designing implant planning in my software, and I'm going to show it how simple it is. And finally, I have been fully reviewing the simplified universal guiding system, and I am going to show you how it is simple. Simple means not simple things, doing simple implant placement. I'm talking about a simple way to make even complicated cases. And this is what I'm going to show to you. So, first of all, we are going to start with the scanning appliance. Do we need scanning appliance or not? And what kind of scanning appliance? Let's go. Most of partial cases need no need for scanning appliance. And as long as most of the cases are partial cases and not full cases, we do not need to do scanning appliance. So when you have a patient, no need to start taking impressions, sending to the lab, making imaging or making a denture or what. You don't need to do that. Almost on these partial cases, no need for scanning ablation. Send the patient directly to take a CT scan. This is said, we are going to talk of full cases. In the case of full cases, not partial cases, but full cases, we have 2 ways to make scanning appliances. The first one, in full cases, like the upper in this case, is to make a case based on what I published and did in 1999. So we made a case where the teeth are visible, okay? The palatal surface in that case was not visible, but now we will make it visible. I will show you how. And instead of placing pieces of metal in the center of each tooth, we make a hole. Until today, we do the same. Since 1999, we do exactly the same. 20 years ago, we've been starting like this. We carry on working like this. In 2001, 20 years ago, I changed for this. We make a duplicate of the existing denture. Of course, you need to get a denture in this case. And you do it like this. This is the scanographic appliance for the lower. And you see that we have a pink base plate and we have ivory teeth. Why? Because in some cases, I can use this to make an immediately loaded implants with a denture, which is going to be used as a fixed bridge using cylinders on top of my implants. And doing that, you will keep the original denture of the patient intact. Why? Because if by mistake or by misses of luck, you're going to lose 1 or 2 or 3 implants, you will go back to the full denture of the patient because you did not deleted it, destroyed it. Okay, so keep the denture of the patient intact all the time because you never know what can happen. And if a bad thing is happening, no worries. You put the denture back and it's finished. You have time to place other implant in another way. For the upper, it's exactly the same as you see here. This is the upper denture that we keep intact and the upper scanographic appliance. What's the secret of that? Is that you have a ratio which is big difference in between the teeth, 30% by weight of barium sulfate and 10% by weight on the base of barium sulfate compared to the powder of the acrylic. Doing that, you have what we call a gradient, which is a big difference in between these two images. And based on this, we can build a denture with this kind of image. We are making mask. What is a mask? A mask is a group of pixels for the base plate and a group of pixels for the teeth. The group of pixels for the teeth will be used to make the emergence of the implant in the center of the teeth or the palatal position of the implant. And the base plate will be used to make the supporting surface of the denture of the scanography of the guiding of the guide. So one is used to show the gum surface, and one is used to show the teeth. Based on this, and this was published in 2002, we can work like this. We have 3 masks. A mask, a group of pixels of the bone. A mask, a group of pixels of the base plate. And a mask, which is a group of pixels of the teeth. In this case, I can do this kind of planning. I have been planning 2 zygoma implant. I have been planning 4 anterior implant and 4 implant in the pterygoid wings at the back. So this is based on the manipulation of imaging. If you don't manipulate images like this, you just cannot do this, okay? And this is still the way we work. Since 20 years, we are doing exactly the same thing. So how to fabricate that? So it is in the chapter of my book, The Art of Computer-Guided Implantology, which has I invited Alan Rosenfeld to be a co-writer, and we've been giving the basis of computer-guided implantology at that time. But for full cases, you are even a more simple way to doing a double scan procedure. So most of the dentists don't understand really what's the double scan procedure. I'm going to try to make it simple for you. So this is coming from Benoit Philippe and Laurent Serres, who are part of the CAI Academy also, and they have been publishing this. You see the denture of the patient here, and you put some pieces of gutta percha. You put 6 or 5. And you take a scanner of the denture alone. And you take another scanner of the patient with the denture in his position in his mouth, okay? Doing that, you will get this result. which is the bone and the denture with a superimposition of the two CT scans. We call that the double scan procedure. And this is available in our software, and this is very simple to do. In this case, you do not have to fabricate a scanning appliance. You can use the teeth of the denture of the patient, but you need to be sure that the base plate is stable. If it's not stable, your surgical guide will not be stable. And if the surgical guide is not stable, you can forget using it. So we call that the double scan procedure. So you select the scan of the denture and you overlay. This is the DICOM registration, and you have nothing to do, it's automatic. So you have the bone and you have the denture. Be careful when you do that the denture, and you see the image of the denture, which is here. Here you get the bone, the sinus, and here you have a void. What does that mean? It means that the denture was not placed in a good position when the radiologist has been taking the CT scan. And this is a big mistake, because when you are going to use the surface of the guide as the surface of the laying surface of the guide, you will get a void, and your implant in that case will be placed in a deeper position than the existing position. So be careful to test this when you are doing a double scan procedure. That's the responsibility of the radiologist. And this is the good aperture marker, and automatically the program will find the good aperture marker and we place the guide and the denture in a good position. So to sum up the scanning appliance, it's very simple. Almost 100% of partial cases, you don't need any scan appliance. And for the full cases, you can fabricate something if you want to use it as an immediately loaded bridge, or you can do it using good aperture point and making a double scan procedure. Period. It's finished. It's very simple. You can lay on this knowledge to do all your cases. The second point is the CT scan native data, and this is very important to understand. And what about the conversion, the cleaning, and segmentation? So the first thing that you need to know is that there are two ways to represent a volume. There is one way which is called the volume rendering, and one way which is called the surface rendering. What you can do on a surface rendering, you cannot do on a volume rendering. And this is why I am going to insist on this point, because you need to know that to understand what's computer-guided implantology. I am going to illustrate with a case with an impacted molar. It's not a wisdom tooth, it's a second molar of a young patient, 16 years old. And he had this tooth there. And the problem was, what do we do with this tooth? Can we put it in a good position? Or do we need to remove it, or we should not touch it? Or maybe we can make a coronectomy because we have the nerve which is coming here. So what's up? How can we take the decision? I took a CT scan, and on the CT scan with 2D reconstruction, I see that the nerve is coming next to the root, but I cannot really decide what to do. Then I've been looking at that image, and this kind of image is the exact same kind of image you have when you work on a CBCT and you see things in 3D. What do you see? You see that there is some impacted tooth here. You see that there is the root, but can you really see what's the relationship with the nerve? Can you really see what's the inferior alveolar coming? You see that there is a root, but can you see the rest? No. So be very careful when you have a CBCT and you see this kind of volume rendering image, you cannot make a decision on that. So you need something else. You need to go from the volume rendering to the surface rendering. Let me show you more. The surface rendering is called the STL. STL means stereolithography. It is a file format, .stl, used for CAD software and was created by 3D System, which is a huge company in 3D images. STL also is known as Standard Tessellation Language. What's tessellation language? Tessellation is like the tiles. You have broken tiles and it's covering all the surface of the pavement, and they have small tiles and big tiles, and they are intricated one into another. It's exactly what you see here. We have triangles. When it's very flat, the triangles are wide. When it's very narrow, the triangles are deep, okay? And like this, you make a surface rendering using triangle. I'm not talking about pixels in the volume. I'm talking about a surface now. And on this surface, we can fabricate a surgical guide, for example. So surface rendering is really different from volume rendering. It's the same case now. Look, this is surface rendering. I move the teeth and the bone. I am able to draw a nerve. I can see the bone in transparency, and I can see my root inside. I can see that there is an impacted tooth, but this is not enough for me. Now, based on the segmentation is making a group of pixels of the bone and the teeth. I can toggle them out, and I can keep the root of the molar, and I can check where the nerve is going. I see that it's no hook. I see that the nerve is in between the roots, but I can pull the tooth up and I will not injure the nerve. So this is only given by the segmentation. If you cannot do a segmentation, you cannot make a decision in that case. Okay, so forget about the image you see based on your CBCT. It is not enough to take good decision. You need to go a step further, and this step further is moving from the conversion. You are converting a volume rendering to a surface rendering. This is the meaning of the conversion. So let's go to the next step. So clinically, we've been opening that, making two buttons, and we've been lifting up the tooth with orthodontic treatment, and then the tooth is in position, and the case is finished, and it's been saved for the patient. So yes, I like to use this because it gives me the good decision to take. Let me take another example. I have many examples. I will take only a few today. So it's a program which is called Easy 3D. It is done by Vacek. So, and this is the impacted canine, and this is the 3D of the impacted canine. So let's go to the 3D. The 3D is like this, and you cannot move around like I've been showing to you because you have only 45 degrees movement, right side, left side, upper and lower. But this is not the way we want to work. I don't know exactly what's the relationship of these tooth before I remove it. So what I've been doing, so you see this case on Vacek CBCT and in the program of Vacek, and now I'm going to show you in our program how it's working. So this is the same case, exactly the same case, the way we've been using it. Here you see that you have the same case with the impacted canine, and this is the same case showing that. You see the movement, you can select all what you want. You see here, you have the impacted canine. When I remove the bone, I know exactly what's the position with the premolar, with the adjacent tooth in front. I know if I can use an elevator or if I use to reshape the tooth before I remove it, not to injure the lateral incisor and central incisor. I can remove the tooth. I can remove all the existing teeth. I can remove the bone. I can check everything in such a way that it's much more accurate before I touch anything than in the VACHEC system. I'm talking about VACHEC, but all are the same. You work always in volume rendering instead of a surface rendering. And this is what I wanted to show you to be sure that you understand how it's working. Let's go to another step. When you are working on a CBCT, you have a lot of scattered images. This is scattered images. These images that you have is based on the metal which is in the crowns here and there. So we need to clean up that. And you see in this case is even worse because the upper jaw and the lower jaw are in contact. So how do you want to rebuild the surface of the upper canine when you see that? You cannot do it. So you need to separate the upper and the lower. Ask the patient to bite on the cotton roll for all cases, partial and full cases, the same. And when you know that you have a lot of metal frames and all that, don't use a CBCT. Send your patient to a spiral CT center, okay? In this case, we've been working on reducing the artifact. We've been removing the canines, and we've been planning like this. But to get this kind of result, it lasts around 1 hour or 1 hour and a half. And if you remove too much, you will not be able to get the right image of the existing bone. So be very careful. Avoid using CBCT when you have a lot of metal, and separate the upper and lower in all cases. Okay, this is an important point I wanted to check with you. So this case is one of my patients of 2 days case. I found that on the OPG this morning, and it is a cyst which is growing up. The patient, it's very painful. So Arshad has been doing the conversion, and you can see here that he's been doing 1 mask of the bone, 1 mask of the existing teeth, 1 mask of the teeth which are in relationship with the cyst, and 1 mask of the nerve. And you see, if we remove the nerve, you have a groove here. This means that the cyst has been pushing out the nerve outside, and we know that we can municipalize. That means that we can remove all the cysts in one time without injuring the nerve in most cases. But we need to know where it is, and this is very useful for the surgeon who is going to remove the cyst. So this kind of images, yes, I want that, and I want to work in a very secure way, knowing what's going to happen. And I never have that when I work in a volume rendering system, which is what is given by all CBCTs. I think this is clear before we go to the next step. So we work on imaging to convert the images, you know what it is, to clean the images, and to scan and to plan implants. So we can come to the case like this with spiral CTs, CBCTs, double scan, optical scan, STL file, intraoral scanners, AxisGuide scans. We go to images and we treat the images. The image treatment is very important. If you don't want to do it, we can do it for you. But me, I don't do it. I always has to be done because I have no time to do it. So image means 3 things, and you have to understand these 3 words. Conversion. Conversion means going from a volume rendering to a surface rendering, and you understand why it is mandatory to do it in some cases. Segmentation means making 3D object you're interested with. For example, the tooth you are going to remove, and maybe you're going to make an immediate placement of implant. So you need to know what's the volume before you're going to do that. And based on that, you can select the exact volume of the implant to place in the missing group. And cleaning is to remove the artifact, but the CBCT is giving much more artifact than the spiral CT. So when you expect to have a lot of artifacts, send your patient to a spiral CT center instead of a CBCT. This must be very clear for you. Conversion, segmentation, cleaning. So based on this, we go out with a AxisGuide.axis file, and we can plan implant. We go to the next step, which is the implant planning. So we go to the plan, and we plan implant. So I'm going to show you an implant planning. I select the tooth, 46. I have the history of what I've been placing there. So I select one done in the history. On the upper right side, you can see the implant. And we are going to click on top of the bone and we place the implant. So if we move by the lower the implant, it will be rotating from the top. If we move from the prolongation of the implant, it will remove from the bottom. We can also remove the implant position itself. We can make it longer or shorter. And when it's next to the nerve, less than 2 millimeters, it becomes red for security reason. What you can do also, and this is unique, you can change the diameter. And every time you change the diameter, you change the color based on the international coloring system: white, yellow, red, and blue. And this is based on the several diameters of your implant brand, okay? So in this way, you don't need to open a file, you don't need to open a list, you don't need to go outside of your image. You can do it directly on your implant. And the diameter is unique in this program. So this is really something very easy to use, even for beginners. So based on this, you can plan implant, and I'm going to show you a case. This case was sent to me, and this patient came and he said to me, I need to make bone grafting because I have no bone. I say, I don't know, sir, if you have no bone. We are going to make a CT scan and we are going to study your case. And after that, he had the baby teeth here, which I removed, okay, virtually. And then I have been planning implant and placed on virtual waxing implant. And I saw that it was not needed to make a bone grafting. And I explained that to him. And the patient was very happy. So you show the good tools to the patient, you are going to sell more cases. This was studied in a study done in US. And when you are working with this kind of program, you are selling more implant because the patients are confident and they trust in your technology, in the technology you are using, more than if you say, I am the best implantologist in the world and I'm going to place the implants in the right position, because this is a lying, and you know it. You need to be guided to get the right accuracy. By hand, you can place an implant with plus or minus 3 millimeters. Being guided, your accuracy will become 30 micron. And this is a big difference, and this is proven. And this is why in all my cases, I use guided implantology, not only difficult cases, all of them. So the implant can be placed wherever you want them to be on these different teeth. I have been removing a root. I check the size of the implants to make immediate load the implant, and I can check in transparency. I can also put orthodontic implants. I'm going to show you in between roots very accurately, which I cannot do without guiding implants. So based on this, now we are going to fabricate a good plan, which is going to come in .axis. And now we are ready to go to the simplified universal guiding system. And I'm going to really simplify things for you, because what you find on the market is linked to a company, and this is the kind of surgical kit that you can find. Most of these kits cost in between $4,000 to $6,000. So you need to do a lot of implants if you want to do that. But all these kind of things are not needed based on what I'm going to show to you. And the big disadvantage of working is that first, This is not only very expensive, but also it is limited to one and only one implant brand. I don't want that. I want to be able to change from one company to another company if I want to do it, okay? And I want to be guided in all cases. So you need to be universal in guided system. It's not because you're going to pay that in an expensive way that you will be universal. You will be bonded with this company. And you need, of course, when you see all these things, a long training curve. This is the reason why they don't do guided implantology, even in the big brands. And some big brands have been asking us to redo the system to make it more simple, which we didn't want, because I don't want to link a guiding system to a brand. A brand is a brand, a guiding system must be universal. So UniGuide drill is the guide I've been designing. And it's a universal guiding system. It's not linked to a brand. Every brand can use it. Allows mixing guide at the dental lab. No need to do it in Belgium or in US or whatever you want to do, and they are going to deliver to you. We can send you a .stl file, and if your dental lab is equipped with a 3D printer, they can print for you, and 2 hours after they can deliver to you. So yes, we want something easy, universal, and next to you. What we want also is that we want limited financial investment, and you're going to check and see the difference, and you will understand that. This is talking to dentists, okay? I am not making research. I am making the everyday practice. And we need a short learning curve to make it efficient in a fast way. And we need also, and this is something that I bring because a lot of people have difficulties to go at the back on the lower. So we've been making special drills very short for the lower. It's unique also. And this will give you in all cases accuracy and security. I show you that. You can work on the bone, you can work on the teeth and mucosa, and you can work also on the mucosa. This is the same. It's not because it's simple that it does not allow you to do everything. We go to a guide, and 3D system is .stl, and this will allow you to fabricate your own guide. The fabrication is done in a 3D printer, okay? With special acrylic, but on a 3D printer. Why we need to be guided? To avoid that, to avoid the implants not placed in a good position, to avoid mistakes of implant placement like this. With our system, you will never put implant like this. So what is the unit drill kit? It's a kit that I have been using since a long time now, but it's a discovery for you. It's a one cylinder only, diameter 2.05 millimeters. And you have 4 drills, 13, 17, 21, and 24 millimeters. 13 is the lowest height that you can find on the existing market of computer-guided implantology. This will allow you to go at the back. And drill diameter will be only 2 millimeters in diameter, and you need no more. I will show you why. This is the guide. This is the kit. So you see there is a big difference in the price of a kit like this and a kit like I've been showing to you. And you can start with this kit tomorrow. No need to save money to buy a big kit. So you will receive a guidelines. So the top of the implant will be here, but the guide will be guided with a cylinder, and there is a stopper. This means that the drill length will be different from the length of the implant, because you have to go through the mucosa, the cylinder, and go to the stopper. So in some cases, you have a 8.5 millimeter here. You will add more to go to 13 on top. And this is the way it's working, and you will have a guideline to know how to do. So I show you one example on 2 missing lateral incisor, where the accuracy is mandatory, because we are very close to the adjacent teeth. And this is what I have been planning with 3.3 millimeter diameter implants. So this is the planning on both cases, and this is the guide. The guide is only to be guided one time on a 2mm drill, and I will finish all manually. So this is what you have, and this is showing what we do. And this is the length of the drills, 21 and 24. We are not at the back, we can do that. So I use this unit drill kit, 13, 17, 21, 24. Or is it a standard drill? No. I have been designing, I don't know if you see that, but there is a small tip here, which is engaging the bone. So it will not slip over on right and left side. It will go, get anchored on the bone and deep in the bone. So you cannot move. And the gauge of the drill is very deep. So you will not get compacted bone inside the gauge of the drill, and which is eating the bone, and which will increase the temperature of the bone more than 4 degrees, and then you will make irreversible lesions inside the bone, inside the surrounding tissue around the implant, and you will use your implant, but you don't know why. Okay, this will not happen with this kind of design. There are a lot of things in the design of these drills. So let's go to the case. I open a flap, I check that, I drill, and my implant is exactly coming where I want it to be, a little lingually to go in the lingual side of the tooth. So, and then I use another system, increasing the diameter with a sleeve, so I cannot go deeper. I have the impact on the bone, I have the angulation, and I have the depth. This is all what I need. So I have my implant. It's a little too high. I make it a little deeper, and I check it. And you can see here that the cylinder, the cover screw is placed. It's exactly where I want the emergence to be. On the same side, on the other side, implant placement and placement of the cover screw. So I cover, we wait. You see the X-ray, you see how accurate I am. Okay, I cannot do that manually, but using only one drill, I have been able to do it. And this is the case, which is finished. But we can do things like this also. We can do that. This is a case where I sent to my orthodontist, and he said, I need to have some implants at the back. So we've been putting anchorage at the back in between the roots, as you can see, in between the roots, very high. So we can lift up the roots, and this avoid using a cap for the patient. So I do this. This is a company which is advertising the system. We place implants on top here, but what they don't say is how they place implant without touching the root. Me, I tell you how to avoid touching the root. You put an elastic here and there, and the elastic is going to pull up the tooth. And this is what we do. The big difference with them is that we know where we are going to place the implants. So this is the guide, and this is our system. So it's placed like this. This is the end of the surgery. You see how high we are. We are high because we want to lift up the roots here. And we are going to put some in lingual also. In lingual, I put one on each side. And after a while, the orthodontist sent back to me to remove these teeth. You see now we are very narrow to the roots. This has been lifted up, and he's going to pull all the teeth back and finish the case. So I want to show you one thing before I'm ending. I want to show you also that we are doing, you are going to say to me, oh, you are going to do simple cases, but we do the same for much more complicated cases. I show you this case that we did for a surgeon in Saudi. Okay, this is a cancer on the lateral side of the mandible, and he wanted to be guided to remove the cancer without removing more bone than what was needed. So we've been working on the program. We've been making a mask. You understand what's a mask now? a mask of the tooth. There was one impacted tooth here, mask of the cancer here, the remaining teeth all over. And these are just guided screws to guide the position of the mask. So you see that we can control all these things. And now we have the upper, we have also the lower, and we are manipulating all these images. And not only that, but we are making a surgical guide. You see here the surgical guide, and the surgeon is going to use this surgical guide, which is going to be secured with a guiding system like I've been showing to you here, there, and at the back. And now, based on the design, is going to be able to remove all what is inside this. Is going to remove one root here, two teeth here, all the cancer, and is going to replace that with a metal frame or with nothing in the first row. So you see that we are working in a very high level with a very simple system. So I would like now to show you a last demo, step by step, showing to you how we do. And the advantage of working in computer-guided implantology, you don't need to buy expensive and complicated tools. You can start what we've been developing, which is called Unidrill kit. Okay, I'll show you one example on one tooth, and you will see how easy it is to use that. The big benefit you will get is that you will get accuracy in implant placement, security, and you will get the fast implant placement, and this is very appreciated by patients. Let me show you that. So this is the patient's mouth. Some implants have been placed, and we are going to use a surgical guide. So you order for a Unidrill guide. This is the surgical guide. The surgical guide is done like this. The underlaying part is going to cover the teeth and the mucosa, and on the outside you will find some drilling cylinders, and you are going to use these drilling cylinders to stabilize and position the position of the implants. So you put it over and you check that it is stable. At this step, it must be very stable. If your guide is not stable, you should not use it. The stability will give you the accuracy. So this is what you have in the patient's mouth, and this is the kit. So you see that the kit is very simple. It's called a Unidrill kit. In this kit, you have a series of drills starting from 13 millimeter in height, 17, 21, and 24. Most of the companies are selling more than that, and in some cases it's very difficult to access. So we've been designing a short drill, a short guided drill, because of the knowledge we have behind this technology. So at the same time, you will get the guide, you will receive this. This is the guidelines. So the guidelines will give you the name of the patient, the type of support, tooth supported on the maxilla, and you will have a series of implants. We are going to focus on one implant, which is in position 25. So the drill length will be 21 millimeter, despite the length of the implant is 11.5, because 11.5 is the height of the implant, and above that you will have the mucosa, you will have the cylinder and the guide. So this means that the drill length will go from this part to the end part. And when you will place your implant, you will stabilize the implant at the position of the bone here. So let me show you how it's working. What is indicated here? What is indicated is the drill length. Okay, so in this case, we are going to use 21 millimeter drill. So this is 13, 17, 21, 24. We are going to use this one. I put it on my handpiece, and I'm going to show you how we're going to drill. The guide is in position, and we are going to start drilling like this. So it's very easy to go down. So I'm in 14. I go in 24, 25. I drill, I go through, I am inside the bone, and I go down to the flange. That's it. I don't need to go up and down, because we've been designing this in such a way that the groove here are very deep, and you will not hit the bone, and you will not get the bone stuck into this position. So these guides and these drills are designed in such a way that you will work in a very secure way, drilling and not increasing the temperature of the bone. I remove the guide, and I am going to blow up all that, and you will see here that there is a small opening going inside the bone. So to avoid that, we are going to make a trephine. If you want to open a flap, you can open a flap, but I will consider that opening an access through the soft tissue is good, because if you don't do that, you will contaminate the implant with the surrounding tissue. In this case, we are going to work with an easy guiding system. So we take a trephine, and we are going to remove the drill, which is a 21 millimeter drill. I am drilling guided only one time, and now all the rest is done manually. So I have a trephine, like you can see here. I go exactly over the position of the drill that I have here, and I go down to this. I can remove it, and you see now the soft tissue is inside your instrument, and you have a full opening, and you can carry on drilling in this position. Now, what you can see here, I don't know if you can see it, but you have the trephine, you have the first drilling, which has been done here, and based on what we need for the final implant, we are going to drill more or less. In this case, we are going to drill up to 2.85 millimeters to place the implant. So I'm going to take a new drill. The new drill will be here, 2.85. I take the drill. I am not guided anymore, but if I'm not guided, I'm going to show you more. I'm going to take a pilot drill. I'm not guided anymore, but what I had with that is the entry point on the bone, it's the angulation, and it is the depth. These are three very important points we need to know when we are placing implant. So I use another drill, which is a guiding drill. Okay, that's it, one time. I remove it, and moving it, you see that you have the access to this bone in a good way. And that is what you are doing in a normal way when you place implant. You don't need to be guided more than that. And finally, I am going to go to the implant placement. The implant placement, after the last drilling, will be done with an implant holder. So I do my last drilling, I show you. One time, it is done. I finish the drilling. I know exactly where I am. I did not make any deviation. I am not making any eating of the bone. And this is perfectly done in a very simple way. This step, we have all what we need. The osteotomy is done. We've been removing the soft tissue. We will have no contamination. And we go to the next step. The next step is the implant placement. So we use a manual implant placement or a drilled implant placement. I am going to use this implant holder. I put it over the head of the implant, and this is my implant that I'm going to place inside the osteotomy. So I'm going to change the speed. I go to 20 turns per minute at 50 Newton centimeters. I go inside, and I am guided inside. I go step by step. I go very slowly. Once again, no need to eat the bone. I go down. I can control the depth. I can control the depth visually. I can also control the depth with X-rays. And here I am. I have been placing my implant. It's inside the soft tissue at the level of the bone. I know perfectly where I am. I don't need to make stitches if I've been working like this. If you've been opening a flap, you will cover with stitches, and that's done. And when you take the X-ray, you will be very happy to see that the implant is exactly in the position of what you wanted and what has been planned. So let me give you another advantage in working like this. In working like this, when it's time to make the activation of the implant, maybe 2-3 months after, you just put the same guide over and you make a small drilling and you will know exactly where is the implant. No need to open big flap. You will know and you will be guided using the same guide to make the activation of the implant. So there are a lot of advantage working on that, not only on one implant placement, but on several implant placement if you need. You can work minimally invasive. This is a big advantage for the patient also. And this will give you a very, very good placement every time you work with the system. And the investment is very limited because you are going to only need to get this Unidrill kit for starting computer-guided implantology. Well, I thank you very much for your attention.
Okay, so this movie was done to really explain to you how to do. I have been giving to you the all the basis of simplified computer-guided implantology. It's much more difficult to simplify than to make it complicated, I can tell you. But now computer-guided implantology is becoming easy and simple to implement from A to Z, from the program to the patient. Okay, that's point number one. And this is mandatory to understand that we are in a different computer-guided implantology area and sphere and world today than before. AxisGuide program is the program I designed, and guides are affordable and even free. So there is no more monopoly. You don't need to buy a program going with a guiding kit for only one brand. You need to be open, okay? So no more monopoly. Don't go into monopoly because in your life you will change implants brand. And there is a very short learning curve in this system. So everyone, because you are not going to go in a different world. You are going to go in guided the first drill, and after you carry on with your own implant system, and you know it. So it's not complicated to implement. It's just to make the first step. When you get the first step, all the rest will be as you used to do before, but you will have the very important points that you need: impact of the bone, length, and angulation. And this is what we give you with this. And this is available in all countries. It's not linked to a company which is going to sell you that. You will need to wait for 2 weeks for that. No, we can do it in less than 1 day. We give you the STL file, we send it to you wherever you are in the world, and you do it printed in your dental lab where they have a printer. And more dental labs are equipped with printer, so no need to go around the world for that. We send you by internet the file, and you can do it. So this is what I wanted to talk to you about. So I did not go into zygoma implants and things that you will never do. I have been going into a very simple way to make even complicated case, but in a very simple way. So this is what I wanted to do, and I think it's very important because talking to the dentist more and more, I understand that this is the kind of things they need to understand. Okay, my friends, I thank you for your attention.